Hello, everyone. Good evening and welcome to ICPA Clinical Series. Today we have the 17th episode, and ICPA Clinical Series is all about solving one clinical challenge in each episode. And in the last 16 episodes, we have solved a variety of clinical dental challenges. And today we have a special topic, and for which we have Dr. Shilpa Sonambekar Lathi, MDS Prosthodontics from Pune. Let me introduce Dr. Shilpa to you all. Dr. Shilpa completed her BDS from Government Dental College and Hospital, Mumbai, after which she secured a merit rank in the entrance exam and got MDS Prosthodontics in MGV, Dental College, Nashik. She completed her prosthodontics and she started her dental practice with more emphasis on prosthodontics and implantology. Dr. Shilpa is married to Dr. Alok Lathi, who is an OMDR specialist, and his keen interest in CBCT and his work in CBCT took her towards digital dentistry. She started practicing digital implantology in her clinic, and she got trained by Dr. Gerd Frasek in Germany in 2018. After which, both Dr. Alok and Dr. Shilpa started working on surgical guides with the help of different scanners and softwares. And in their practice, most of the rehabilitation work is done through the guided prosthodontics, guided and digital implantology work. And she says that she cannot even imagine her practice without digital implantology. And as she mentions in her abstract, there are many dentists who are not able to make full use of guided implant surgery because of several myths and misconceptions surrounding this topic. So she has chosen this topic to bust these common myths. She has chosen 7 common myths which she will bust in this lecture to help people master guided implant surgery. So she will cover when not to choose guides for implantology, and when you choose, what mistakes to avoid, and how to make use of the full potential of guided implant surgery. She is the founder and lead prosthodontist at Digital Dental Implantology, or DDI, since 2018, and she is certified as an integrated implantology trainer for Dentsply Sirona since 2018. So it's my great pride and privilege to call Dr. Shilpa Sonambekar and to let her start this lecture. Dr. Shilpa, the show is yours.
Thank you. First of all, should I start talking?
Yes, please. Your slides are visible.
First of all, okay, firstly I want to thank Dr. Rajiv sir and ICPA Health for giving me this opportunity to present my ideas and views on guided implantology. Thank you so much, sir, for your faith and for your support. You've been very kind. Um, I have, been doing guided implantology for quite some time, and I have been helping my friends and colleagues from all over India in that field. But there are a lot of questions and queries which people tend to have about guided implantology. So I thought, today, why not talk about it and share my views about the same. So I'm going to talk about 7 important myths that you need to take off your minds and start doing guided implants. So there are basically 2 types of dentists that I have come across. The first group is the one that adopts and believes in freehand surgery. They are the ones who love the adrenaline rush that they get with the implant surgery. And the other ones are like me, who want their life to be easy and do not want a lot of stress and tension while they are performing their surgeries. See, either ways, whichever way you want to go ahead with, I think works. So whether you think you can or you think you cannot, you're right. One of my friends shared this on FB and I really liked it. I quoted Adam Grant says, "The hallmark of an open mind is not letting your ideas become your identity. If you define yourself by your opinions, questioning them is a threat to your integrity." So if you see yourself as a curious person or a lifelong learner, changing your mind is a moment of growth. So this lecture is dedicated to all of you curious minds who want to adopt and learn new techniques and change their way of practicing. We have all heard of this story of the wise crow, who was very hardworking, and he was very thirsty, and he put all those pebbles into the flask and the water level rose, and finally he could drink his water. And the moral of the story was hard work solves all the problems. But that was an old crow. Modern crows actually have better techniques, and they can easily and fastly get what they want. So all you have to do is update yourself, because it saves a lot of extra effort. So let us come to the first myth, which is guides are for beginners and not for experienced surgeons. My take on this is, it is good to be brilliant, to have strong core competencies, but all days are not your days. Okay, sometimes it's just that you've had a fight with your spouse, or just planning goes haywire, because we are all human beings at the end of the day. We have our own moods, and we cannot promise to be perfect every single time. We tend to make mistakes. That is what makes us human. So this was one of my case. It looks good. You see the IOPA, it looks nice. You see the final result, it looks good. But what lies within, only I and my lab person knows. What went wrong here was the screw access holes have come really buckly. If I would want to do this case again, perhaps I wouldn't do it this way. So the difference between freehand surgery and guided surgery, according to me, is just like the automatic transmission and the manual transmission of cars. Okay, it is not that you can just go on the road with the automatic cars. You have to know the rules, the traffic rules. You have to know how to drive the car. You have to know the all the signals, and only then you can actually drive your automatic car. It's easier than driving a manual car, but you have to have the sense of driving first. Okay, there are these cars that have come. They are this Google car and there's Tesla car, which would not need drivers. Implantology also is moving in that direction, and there are certain countries where these techniques have been approved by their bodies. Um, but guided implantology today is like an automatic car. So you have to know what implantology is, but it just makes your life easier. So, for whom is guided surgery warranted? Is it for freshers or experienced surgeons? I don't think that's the criteria. I think whoever wants to place more implants, whoever wants greater safety for their patients, and also these days for themselves, because if the patients are not safe, the doctors are not safe anymore. For whoever who wants fast and easy workflow, who wants to save chair side time, who wants to do things in fewer sessions, and who wants stress free implant placing. Also the doctors who want their patients to stay loyal to them, because people do not trust human beings, people trust machines more. So when you tell your patients that it is the machine who is working more for them, they will trust the machines more, they will trust their dentist in turn also more. So these are a few articles that I came across, and I would like to share them with you. The first one says that surgeons under stress make more mistakes in the operating room. And there's no doubt that surgery is its own stress. So when you're stressed out, you kind of make simple mistakes. There's this another one that shows the effect of chronic stress, because if you are doing surgeries every now and then you are bound to have a stressful life. And what chronic stress does is, if the stimulus is too intense or if the duration is too long, then the coping mechanism can fail, and there can be maladaptation and chronic diseases. So anybody who does not want to, go through all these terrible health conditions should go for guided surgeries. Also, they have said that stress impacts health by modulating the rate of cellular aging. So there's telomere shortening, so in response to chronic life stress, and whoever wants to live a long life, I think should go for guided surgeries. There are a lot of things that you think, as a dentist, the patients come to you because they want tooth. Okay, how you give them the tooth is all up to you. So there are a lot of things that you're thinking when your patient is sitting on in the consultation. You're not only thinking about the patient's pocket, but you're also thinking about his or her medical history, age, how the soft tissues are, how the face type is, and you want to put it all together, and then you're planning something in the patient's mouth. You're treating the patient entirely. You're not just treating one single space. So you're looking at all the things and you want to put them all together. You have all this information that you also get from CBCT, and then how do you merge all this information? So for that, you need guides. There are a few surgeons who say that guides add unnecessary cost and they reduce net profits. So guides are for surgeons who do not want to manage such cases. As you can see these slides. Fortunately, are not mine. These patients are not mine. But no, I God forbid, nobody should have to face such issues. So you can see that the angulation is not right. You can see that it's impinging on the adjacent tooth because the tooth is tilted. There's another one that's lying very close to the nerve. It is also for the dentists who are like, who don't want to be like Dr. Bunny. So Dr. Bunny here has given teeth to the patient duck, and he has given buck teeth to the duck, and he's asking him, by the way, what's the problem with you? The duck is not happy with it. So it is for the dentists who do not want to have such situations after they have done treatment, because anything that you do after treatment is excuses, and anything that you say before you treat are explanations, right? So guides are not for just for experienced surgeons. Guides are for these people who wanted their treatments to be predictable. They want safety and they want to be efficient. So when I started doing guides, I wanted to, because I'm a prosthodontist, so I wanted the process to be perfect. So I started using all these in-house guides. I started using clear acrylic stencils to make a tooth, make a stent, then put GP point in it, then ask the patient to go for CBCT, and then see where the tooth is coming, and where the how long the implant should be, or how much residual bone is available. uh, there was other way where I started, you know, making the guides in another way. I used to put a tooth there and then use that tooth for splinting as a temporary processes. I started using Essex appliances and started giving them later as professionals. I also tried making. I read about it in some article, and I started making these putty stents also. Okay, so you add the tooth, you add putty on top of it, and then you make a slit, and then you all these pilot drill guides, but they don't really work. I started using tooth as a guide. So you keep the tooth, you slice off the crown, you drill through the roots. uh, it also works, but every time you do not have these situations, and sometimes the bone um, does not behave the way we want. Also, if you drill teeth, the teeth are stronger, the drills wear out quickly as compared to drilling bone. Then I came across this device I got from Osang. It's called as bone pen. So it has these cylinders, and you can place your implants parallel to each other, and it's pretty good actually. I used it, but what happens with this is this: there's no buccal lingual positioning or angulation. There's no limit that can be put to buccolingual positioning. The mesodistal positioning is quite easy to achieve with bone pen, but buccolingually you can go elsewhere. Also, the ankylation is not under control. So, what you should think about is begin with the end in the mind, as Stephen Covey has said in his book. Before you start anything, learn how to finish it. And that is why I started going forward and doing this computer guided approach, because it saves you a lot of chair side time. You have to spend time, but it's not when the patient is in the chair. And we still are making guides for people who want us to make for them. So the second myth, that CBCT is inaccurate, because we have a CBCT center. We have 4 across the city of Pune now. A lot of people say that you apply your implants there and you make those markings, and when I enter the site, the height of the bone is something else only. Why is it so? It's simply because a lot of times how you make your markings will tell how much bone is available. Okay, like in this case, as you can see in the first picture, the available bone is 15.19. In the second picture, you can see the available bone is 14.07. So it's about 1 millimeter difference. And why does it happen? We all know the Pythagoras theorem, right? The hypotenuse is always longer than either of the sides when it's a right angle triangle. So how you mark on your CBCT may be different from how you enter your surgical site. And that is why the, the, the height that you come across during surgery could be different. What we simply did was to check the accuracy of the CBCT when it was like really, really long time back. It was in 2012. What I did was I placed an implant. I knew the size of the implant. I asked the patient to go for a CBCT scan, and then I measured the dimensions of the implant on the CBCT. And I found out that no, it's accurate. It cannot change. If the implant is 4.5 by 10 in the patient's mouth, the implant is 4.5 by 10 in the CBCT as well. So there's no doubt that CBCT is accurate. There's this third myth that people have asked me often. Guides are not autoclavable and irrigation of the field is not possible. Hence, guided implants fail a lot of times. Well, not true. Uh, these days, you have printing resins as well as you have milling blocks that are autoclavable. So we make guides that you can autoclave, properly autoclave, not just cold sterilization. It's proper autoclaving that is possible. And then irrigation of the field is not possible, is what people think. Well, there are some systems that offer internal irrigation of the drills. Okay, one of which is Ankylos. If you are bothered with irrigation of your drills, you might choose a system that helps you achieve this. Honestly speaking, otherwise, there are a lot of drills which use external irrigation, even in the normal surgical kits, and external irrigation works just fine. So, even if you choose a system that has external irrigation, you can externally irrigate the drills, and irrigation is possible. And if you are very specific about wanting to irrigate internally, then there are systems that give you that option. You may choose one. The fourth myth is guided surgery is always a flapless surgery. Not true. Guided surgery, like any surgery, can be flapless surgery, or you may choose to raise a flap. So, raising a flap or not raising a flap depends on the tissue that is available, the attached tissue, the amount of attached tissue that is available, and the comfort of the operating surgeon. So in this case, we just punched out the tissue because we had ample connective tissue there, ample attached gingiva there. In the other case, there was not enough, so we wanted to do GBR. We raised the flap and we placed the implant, did the GBR. The implant went well, and we could increase the width that we had initially planned to. So guided implants surgery can both be flap with by raising the flap or flapless. You can just punch the tissue out. It is your choice altogether. The fifth myth is that cases that need sinus lift or GPR or that have lesser mesodistal space have to be done freehand. But not true. Again, there are kits that allow you to use um, their own ways of lifting sinuses. So, say for example, Ostem or Hyosin have their one guide kit, one guide gasket as they call it. The lifting has to be done through the guide. The implant goes through the guide. They also have their narrow ridge kit. A lot of kits like BNB also have their narrow ridge kit, and you can use those kits for places where there is less mesodistal space. For people who love using Denza burrs, so Verza also has their own guided kit. You can use that kit, and only you have to make it available. It is not currently available in India, but if you can procure this kit, then also it is possible to use Denza burrs and do guided drilling, because Versa does not have their own implant drivers, but you can do guided drilling with Versa burrs. So it is drilling or expansion. There are a lot of dentists who say that pilot drill guide is as good as or sometimes better than full protocol guide. If you really want to go ahead with pilot drill guide, it is possible if you have step drills, wherein the drills are in steps. So there's the initial lower part of the drill that guides the further drilling. In that case, maybe you can go ahead with pilot drill guides. Then there are some cases where you need expanders. There are some kits like the one from BNB. They have guided bone expanders. So you can use those bone expanders also through the guide. That is also possible. But if you want to go for a pilot drill guide and then use the expanders that you have in your kitty, that is also possible. What makes a difference here, what is important here, is to know what kind of implant you're using. So if you're using an active thread geometry, then what happens is that your implant can change direction and it can go away from the osteotomy. With passive thread geometry, the chances of that are less if your bone is dense. But if the bone is not dense, then that also is a possibility that you're drilling elsewhere and your implant goes somewhere else altogether. So I will not say that pilot drill guides are better than full mouth or fully guided surgeries. So here is one case that we did. So this shows fully guided protocol. Everything was done through the guide. I can see the implants that have been placed from right to left. I will also want to show you the maxilla case. Here it was very critical because as you can see that there was very little bone and we had to engage a septum to engage the posterior implants. Also the ridge is very thin, but this also was completely guided. So the drilling and the implants went through the thing. Here also you can see that the septa has been engaged. No signs here. So it's not really the guide that is at fault. It is the case that is taken up for fully guided surgery and the way the guide is made. If it is made perfectly and if the protocol is followed to the T, It will never go wrong. And the last myth that they say is once the guide is fabricated, nothing can be changed. Well, that is not true. A lot of guided kits will let you change the length, will let you change the depth and the diameter of the implant because um, there are certain drills for certain length of implants. So you can change the drill that you want to use. Say you want to place, you've planned a 10 millimeter diameter, 10 millimeter long implant, and you want to place an 8.5 or say 8. What you have to really do is change the drill. Use a 8 millimeter drill. If you have planned a 8 millimeter implant and you think that you can go deeper, you can see in the planning that there is enough space. You choose a longer drill and place a shorter implant. Just go deeper. Also, the diameters can be changed up to a certain limit. So if you have planned a 4 millimeter implant, you can place 3.5 millimeter implants as well. You just have to drill a drill less. What cannot be changed, however, is the position, the mesodistal position, or the buccolingual position, and the angulation, because this most of these guides use a cylinder in a cylinder approach. So the angulation or the position cannot be changed once the guide is fabricated. So when is it that you should not use guides? First and foremost thing is if you have no knowledge about the guided kits, you have to know your tools. If you know your tools well, only then you will be able to work well. Secondly, if there is thick or overly compressible or flabby mucosa, especially in edentulous cases, when you are making a guide that rests on the soft tissues, and if the soft tissues are compressible or very flabby, then your guide will not fit well. If your guide does not fit well, your implants will not go in the right direction. Third is if you make ill fitting dentures and you use these dentures as references for making your surgical guides. So a lot of dentists, they're too lazy to make new set of dentures because they're scared that if we make a new set of dentures, then perhaps the retention will deter the patients away from implants. The patient will be happy with their dentures. But ill-fitting dentures, when used as template for making guides, because the edentulous protocol requires dentures and they need to be well-fitting dentures. Then if you are planning a tooth supported guide and your abutments are mobile, naturally your guide is not going to be accurate. Also, in certain cases when you have restricted mouth opening, especially in the areas of second molars, a lot of times the mouth does not open enough, wide enough. So for those situations, you will not have enough space to have space for the sleeve as well as the guiding cylinders as well as the head of the handpiece. So minimum clearance needed from the opposite arch is 35 millimeters. So if you have that much space from the opposite arch, only then you can go for guided surgery in that particular area. So why, when I was talking about mobile abutments, why I was saying that is, if you have say 1 minute deviation, which is about 6 degrees deviation at the top or at the crest or at the top of the sleeve, then you will have about 1 millimeter deviation at the end of the cylinder, and you will have about 2 millimeter deviation at the apex. So the crest of the implant will be 1 millimeter away, and your apex of the implant can be 2 millimeter away, even with such a small deviation in angulation. So if your guide moves, which will move only if your teeth move, because the guide is resting on the teeth, then your implant will also not go in the right direction. So make sure that the tissue that you're using as rests are stable. If they're not stable, make them stable. Also, you can use anchor pins or anchor screws. If your abutments are mobile, you might as well take the support from the moon so that your guides are not mobile. If your guides seat well, your implants cannot go anywhere else but where you've planned them. So, a typical case usually requires you to have an intraoral scan or an impression, which is then scanned by the labs. You will need a CBCT. Both the data are merged and the implants are planned. A guide is fabricated. Some systems require spoons, and your drills pass through the spoons. The other systems use guiding cylinders. Uh, and you just go ahead with your osteotomies and place implants. I have done a lot of cases. I've stopped, documenting the same type of cases now, but not always go right. So, from I won't do it to I cannot do it to I want to do it to today, you all have reached how do I do it. I hope you all move up the stairs and, finally someday when we meet, you say, yes, I did it. So let me know which step you guys have reached. So at the end, I just want to say that when technology is offering you some help, uh, just use it. Don't say that you're too busy to adopt any change. Thank you.
Thank you. Thank you, Dr. Shilpa. It was amazing. It was a short, concise, but highly enlightening session. And you cleared so many concepts. And I really liked one thing that you spoke about. It was an unexpected thing for me, but I've been reading on it off late. The telomere length, with chronic stress, the shortening of telomeres. I was just reading about how you can reduce stress in life with meditation or anything.
Yes,
And
sir.
people are doing neuroscientists are doing experiments whereby they are checking how much the telomere length is increasing. So that was uh, what you can say, exactly what I'm reading nowadays, and I happen to see in a prosto lecture. So that was total a shocker for me. So
So
tell me
what
about
also happens is, I'm sorry to interrupt, but what also happens is that we have very limited um, time as surgeons, because as we age, our hands may start shaking, our vision gets blurred. So we have very limited time span, and in that time span, you really want to work well. You do not want so much stress for yourself. I think we all deserve, to have a stress-free practice.
can you can you tell us something about your training in digital implantology? Dr. Gerd Frasek and Dr. Abhay Lamba also you have got trained from.
Yes, sir. Yes, sir. First, Dr. Abhay Lamba has been doing this, but he mostly does it for himself. He is a great surgeon. He also has now learned dental technicians skills. Uh, he was using CIREC, and he had an in-house CBCT, and he was able to do a few surgeries guided when a lot of people were doing it wrong. So
Okay.
we requested him. It was Dance Fly. He also used to speak for Dance Fly Sarana back then. And then we went his practice and we saw how he works with it. Dr. Gerd Frasek also has been teaching a lot of dentists. Um, with Gerd Frasek, I not only I learned how to integrate the two platforms, but he also taught us how to teach. So it was train the trainer program in Germany.
Okay.
Then we had Dr. Dan Hirschbach, who is also a SIREC speaker. He had come to our practice, and that was, I think, the last thing that I learned about integrated trauma. And thereafter, I have been doing my own work,
Okay.
trying to integrate as much as I
So
can.
right now in your practice, no freehand implant placement at all.
Oh, very very few. Only when I am like when the patient is like uh, has no time whatsoever. So if the patient wants to rush back immediately, only then, or if there's only limited space where the guides and the drills cannot pass, only then. But I make sure that i I
Whenever
plan
there
it.
are multiple implants, you will not take any chance and you will go for guided surgery.
Yeah, I usually, whenever possible, I go for guided surgeries,
Okay,
and I
great.
do not charge my patients for guides. The It is for my benefit, it is for my relief, it is for my satisfaction. The patients have all the right to get the right treatment, and if you want, you can charge the patients, but I don't, because it,
Does it happen that you tell them that you are going to do it in guided
I always
implantology,
tell, I
and it will
always
add more cost? It will add more cost. Is how common is it that patients say that guided surgery is adding more cost? Can you reduce that, something like that?
I usually do not charge my patients extra for the guides, sir, because guided surgeries kind of save you a lot of extra costs. A lot of implant
So you
systems
gain there. You gain where you by reducing the time and the anxiety and the
and
uncertainty.
and a lot of time prosthetic components, and
Yes.
also a lot of times the prosthetic failures. It saves you a lot of times implants also. The implant failure rate also goes down because you can be 100% sure that your implant is going in the right place. So, and when you are confident about it, your patients can see it. Besides, I don't think your patients um they don't care how you do it. They just want it right. They just want their tooth to be right. How you
Yes.
do it is none of their concerns. But if you tell them that I use computers and guys, and if you show them their plan, they kind of trust you even more. Like I said, I didn't
Yeah,
things
that was
don't
the
trust
point. That was the
fellow
point.
human
Yeah,
beings.
that was the point. That was the point I was trying to make. When you tell them the whole
Yes,
treatment plan and you tell them that this is guided surgery and it is going to add more cost, and they say why
they
it is
just
adding more cost, and you suddenly show them the entire 3D thing, you show them on the screen, then I don't think they
yes,
will have any problem.
yes. You can actually show them their smile also. If you have in-house softwares, you can show them their final outcome, and if they love it, they usually don't bargain. And I really think that patients then will not look for other options. Otherwise, there are options A and option B in dentistry. But when they know that you're doing it in this way, they will go ahead with you. So patient compliance is high.
Okay.
Besides, you can also always tell them that now there is 0% chance of operator error. Okay.
Okay.
So, and companies usually they have warranties for their products. So manufacturing defects are also very 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 less. So what remains is only patient factors which are left. In case if things do not go the way we would want them to. So you can. They also have that in mind that okay, इनसे तो गलती नहीं होगी, अगर होती है तो हमारे बॉडी में कुछ गड़बड़ हो सकता है.
Acha, I also wanted to ask you, in your digital dental implantology, you do guides for your colleagues also. A
Yes,
lot of clinics send you their work and you provide them guides.
yes.
Which is the commonest work that is outsourced to you from other dentists? What is that common requirement where
More
where they feel they need a guide?
um especially in anteriors, people think that guides will be better. But honestly speaking, there are more number of single or tooth supported guides. So there are some teeth missing, and then people send with
Yeah, that's what
fully.
I wanted to know. Do
How-
they ask for single implants also, or only
Yes,
for multiple implants and aesthetic region?
no, for single implants also.
Okay, okay, okay,
They have started asking, and
okay,
somehow people these days trust tooth supported guides more than fully dentulous guides. And I have been trying to tell them that please don't go ahead with pilot guides for full mouths. Please go for fully guided protocols. If you do it right, it cannot go wrong. You
okay,
just have to know how. You just have to learn a little bit. Once you're done learning, you cannot go wrong. And people who have trusted me and followed have been happy so far. With
okay.
full mouth guide cases also. Immediate extraction cases we've done. I have done soft shield cases. So the extraction is done freehand, but implant goes through the guide. The guide is only about placing the implant in the right place. So once it is in the right place, you can add, subtract, whatever you want to do. You
Great.
want to do GBR, you can do whatever you want to raise a flap and see all the implants from all the sides, you can do that. What happens is just if you raise a big flap, it takes away the blood supply. So whenever it's possible, you should raise it to the minimum. That's what they say these days.
Great.
And
Now,
you
what
know
we'll
this,
do is we will take some questions
right,
sent by the people who have registered for this show. So the
right.
first question is, why are surgical guides so expensive? With budget-centric mind of patient, adding 3,000 to 4,000 rupees is becoming a challenge. So how do you want to help this dentist who wants to ask this?
Like I said, several systems have additional costs for prosthetic components. So straight abutments usually come with packages, and they're pretty cheap. But if you have to go for ceramic abutments, if you have to go for angulated abutments or multi-unit abutments, then the cost increases.
Okay.
And also it adds to the the mechanical stress, the cantilevers that are added. I mean, aesthetically you can take care of these, with the angulated abutments, but still the implant trajectories cannot be changed. So what I really feel is that if you want to have a good night's sleep and not be worried about how this implant will fare, because once you place an implant, they say you're married to the implant. Okay, your patient pays you once, but then will see you for the lifetime.
True. True.
And once that implant to work, he might not complain if his adjacent tooth, his natural tooth fails. But if his implant fails, he feels, oh my god, I paid a bomb for this. So if you do not want follow-ups, or if you do not want a lot of repair and maintenance work, I think investing a little bit initially, and then showing your patients also, that I have done whatever I can do. I think that is how I like it to be. So
Okay.
you're paying for the implants, you pay a little bit for the guide, and then be tension free.
And as you said, the moment you show everything, the 3D thing on the screen,
Exactly. The
that
patients,
improves, that automatically improves the patient's compliance.
it definitely does, it definitely does.
Okay. So next question, it's a set of questions. Somebody has asked multiple questions together. Let me read out all of them together. When to use surgical guide or implant guide? Would it be better to use in open flap or closed flap in patient's mouth? Because so many people say that it is not always accurate. So kindly throw some light on this area.
So like I
I
mentioned in
think
the
you have
lecture,
covered most
whether
of this. Yeah, you have covered it. You have covered it. Most of it you have covered.
so if you want to raise the flap or not, does not depend on whether you're doing guided or not. It depends whether you have ample attached tissue or not, and whether you need it there or no. There are few people who think that even if there is not no attached tissue, the implants work. There are few who insist that there should be at least 3 millimeter of attached tissue around the implants. So what you believe in is how you will go ahead with the case.
Okay. Dr. Meenal has asked, I want to know the steps involved in taking impressions for making surgical guide in full mouth implant rehabilitation.
In full mouth rehabilitation cases, there are two ways to go about it: whether there are teeth present in the patient's mouth or not. So if there are at least three teeth present, we can use those teeth as abutments. If they are firm, we can use those teeth as abutments, and we can make guides using those teeth. In that case, you just have to take a simple, alginate impression. You just have to make an alginate impression and pour the models and send it to us, or you can send it to your nearby. Most of the labs are digitized these days. So most of the labs have, scanners. So you can send it to your lab. If you do not have a lab that has a scanner, you can send it to us. If And you can send the DICOM data of the CBCT. If it's a fully edentulous case, and then you will have to make a conventional complete denture, a well extended, well seated, well retained denture with perfect occlusion. So because your denture is used as the template, so the teeth
Yes.
setting is used as the final teeth position. So implants are planned according to that teeth setting, and the fit of the guide is based on the intaglio surface of the denture. So the softwares copy the intaglio surface of the denture as the intaglio surface of the guide. So if the denture fits well, the guide will fit. If the denture does not fit well, the guide will move. If the guide moves, the guide is not accurate.
Okay, okay. In case of resorbed paper thin ridges, can guides be successful?
Yes. So most of these kits have drill flattening, guide flattening drills. So they will flatten the ridge first.
Ridge.
So your so most of the thin area, because you're planning your implant totally in the bone, so naturally the thin area, the knife edge ridge area is going to be drilled out anyway.
Okay, okay. The next question is, I don't have CBCT in my clinic, nor do I have any intraoral scanner. Now, what I should do if I want to get into guided implant surgery?
It's okay if you do not have a CBCT in house. Most of the cities these days have CBCT centers, so you can send your patient to the nearest CBCT center. But if you want a guide, a CBCT is a must. Intraoral scanners also, like I mentioned before, you can make impressions and send it to your lab that can scan your models, or you can send the models directly to us. We will get them.
Okay. Next question. Okay. When planning a tissue level guided surgery for an Olonex case, if the crestal bone is really thin and needs lot of reduction to flatten it out, how do we go about doing this case? Should we place the implant submerged inside the bone and then reduce the bone, or better to do a bone level guide? Also, what if buccal augmentation is required in the form of a GBR? Then how do we plan such guided cases? Here, the denture has already been fabricated and dual scans have been done. I think this is by somebody who has been doing this and he has actually faced this problem.
Okay. Uh, it's a good question actually. What you can do is you can place your implants, then you can raise your flap and do your GBR, release the flap and suture it. Just like how you would do it otherwise. It's just that your guide is going to place your implants in the right position, in the angulation that you would want it to be. And then wherever the implant is exposed, you can add GPR, do GPR and
So open
suture.
the flap, place the guide, place the implants, take it out, and then look at
Yes,
which are the areas which require augmentation and then go for GBR.
yes. Or in such cases, you can go for pilot drill guides. You can do drilling from the guides. You can then raise the flap, then place implants, do GPR, and then suture.
Okay.
if if
And
because there are
now,
that the implant should not touch you know the soft tissue anyway.
okay. Now we have come to the last question. When we want to do a full mouth immediate extraction and implant placement, how do we make use of guided surgery?
um, so this depends from case to case. A lot of times there are teeth that can be retained, which we can use for support. What we can do is use those teeth for support, remove the teeth that will come along the drilling path, place the implants, remove the guide, remove the remaining teeth, and then you know finish the case. What can also be done is, even if you have teeth in those strategic positions only, you can digitally extract the teeth, plan a guide, and take support from the both. So you have anchor pins that are available, and you uh, use those anchor pins. So virtual extraction is done. So when you go ahead with the case, you extract your teeth first and then place it.
Okay. So that completes all our questions. It was a great session, Dr. Shilpa.
Thank
Sonam
you.
Becker, Lathi has enlightened us in a very, very practical way. And all those seven myths are real clinical challenges which people face in their day to day implantology. I sincerely hope and I'm very sure that this lecture has given a lot of insight to all those people who were carrying multiple misconceptions about guided implant surgeries, and hope will be they'll successfully overcome these and incorporate guided implant surgeries in their practice.
Yes, you have to someday, sir, I think, because initially it was like there's always a learning curve to everything. Initially, we had normal X ray machines and normal X ray developing boxes. Then came digital X rays. You have to learn the software for using digital X rays. You cannot say that, I cannot do it and they don't bend, and it's not the norm. So they have, like, there's a little learning curve every time, but you have to adopt. If you want to be competitive, you have to adopt.
Great, great. So that brings us to the end of episode 17. And I must say here that we are in the month of August. And August 2021 was the month when we started ICPA clinical series. And today we have completed 17 episodes. In 1 year, we have completed 17 episodes. And as with every episode, in the next 2 days, we'll be sending the 5 point summary of this lecture as well to those people who registered but for some reason could not attend this session live. Along with 5 point summary, we will also be sending the YouTube link of our playlist that contains the links to all the 17 episodes. So we wish you happy watching and happy learning with ICPA Clinical Series. And the theme of ICPA Clinical Series is each episode one clinical challenge. And because of experts like Dr. Shilpa who come here, enlighten us, and solve clinical challenges, people have been able to take maximum use of these episodes. So thank you, everybody. Thank you, Dr. Shilpa. And I wish you all the best, you and Dr. Alok, for DDI, Digital Dental Implantology. All the success to both of you. And to all the audience, wait for the 5 point summary and the link to the recorded lecture. And we'll soon come up with episode number 18, ICPA Clinical Series. Bye bye. Good night.